one for Dr. Miller, also on the subject of breast cancer. And somebody wants to know, generally speaking, if you can give an answer whether it's better for a breast cancer patient to get a mastectomy or lumpectomy.
The issue on mastectomy versus lumpectomy, for about 90% of the patients, a personal decision. There's no difference in survival. The recurrence rates in the breast or on the chest wall with current technologies is in the low single digits, in the 1 or 2 to 3% range, regardless of which technique is used. The real issue in breast cancer is not so much what happens on the chest or in the breast anymore. We've really, I won't say we've absolutely mastered it, but we've become very close to it. The real issue is whether or not the cancer cells have migrated into the bloodstream and moved away from the breast. And the real issue these days is managing the bloodstream. So if a woman chooses to keep her breast, she can make that decision very safely about 90% of the time. There are exceptions to that. But really, decisions should not be made in the majority of cases on survival.
Here's a question for Dr. Cohen. Someone wants to know, what's the latest research on the body's, using the body's own immune system to fight off cancers? We heard a bit about that a little bit ago.
Oh, I think I want to punt this one to Dr. Glassby. But like he explained in his slide, and you may have understood it or not understood it, but the cancer cells have developed a very adaptation. One of the sort of mutations that occurs in the cancer cell is their ability to put a signal out there that actually tells the immune system that I'm not a cancer cell, I'm actually a normal cell, and don't take me or don't kill me. And what we've discovered is you can throw a blanket over that receptor and say, and the immune system is able to identify that cell as a cancer cell and fight it. And we have clinical trials that are open at UCLA, soon to be open hopefully in the community as well, not just on Westwood. But and this mechanism or tool in fighting cancer is now changing the outcomes for patients, not only with melanoma where it was initially discovered, but now with lung cancer. So.
Dr. Ashuri, I don't think we've talked much about diet yet, but here's a good question. How often and to what extent are patients advised to change or monitor their diets for the specific purpose of aiding their treatments? And does dietary advice take into account organic or sustainable foods?
I'd like to punt that to someone else, too. I think I'll use that as a stepping stone to really urge or discuss integrative oncology, which is a field that's started to grow in the last couple of years. And I think there is a big part in your diet, we have data on that actually, with your diet, your exercise, and even some supplementation on outcomes with cancer. So it definitely plays a role. In the clinic, we also see that it plays a role in terms of people whose diet and exercise changes while they're on chemotherapy in terms of their tolerance, in addition to the drugs we use to help us get the chemotherapy in. What nowadays I usually recommend with our patients is that they see some sort of integrative oncology consult in addition to us, whether it be our East-West medicine team or whether it be our SIMS-MAN team at Westwood, who will hopefully be here locally too soon, to help us with, in terms of diet, supplements, and other emotional support even, and cardiovascular activity that could help them get through their chemotherapy and also make them more healthy once we're done with the chemotherapy. Hopefully that answered the nutrition.
Let's see, we have a question about community support. Jody, I wonder if you can answer this one. Someone says, I'm a newly diagnosed cancer patient and completely overwhelmed by the massive amount of information I'm finding on the internet. Where do I start figuring out my options?
I'm not sure if it's politically correct, but I would say get off the internet to start. There's certainly a lot of good information on the internet, but as a layperson, I can speak to my own experience when my parents were diagnosed with cancer, and it created, I think, probably more anxiety than information. So you need to be really careful about what you do with the information when you get on the internet. And I think it's really important to talk to your healthcare team and be active and a part of that team. And I'm impressed with the physicians that I get to work with who are here in this room who want to be a team player with you as a cancer patient and with your family. So make sure that you ask questions and that you also talk to other people who have gone through this journey and get their support and information. I think that's oftentimes more supportive, and people find hope and ability to get through it that way.
Dr. Miller, here's a question a lot of people probably can relate to. Someone says, I'm experiencing extreme exhaustion as I go through radiation treatment. What causes the exhaustion, and what, if anything, can be done about it?
Fatigue is a common problem across the spectrum in terms of cancer therapies, including radiation. The physiologic mechanism is not well understood. The assumption, and maybe correctly, is that the body is put into a high state of repair and resources are being essentially exhausted on the repair as opposed to being used elsewhere. What we have learned, and we've got good data to back it up, is that exercise concurrently with the treatment is phenomenally helpful. What I'm going to quote is a study that came out within the last 2 weeks. Actually, it was related to chemotherapy, but the crossover is applicable to the women going through radiation treatments for breast cancer. And basically, they took 3 groups of women to a gym. And group A was had 30 minutes of aerobic exercise, and group B had 60 minutes of aerobic exercise, and this was 3 times a week. And group C had 30 minutes of aerobic exercise and 30 minutes of weightlifting, light weightlifting. The third group did substantially better than the other 2 groups, and actually both of the groups that exercised for an hour did dramatically better than the group that only exercised for half of an hour. They were wise enough not to bother with a control group, because we've known for quite a while that the lack of exercise is just not really a reasonable option. So,
back to Dr. Morlino. We heard you talking about some of those advanced diagnostic techniques a bit ago. Someone wants to know, what's the difference between a PET scan, a CT scan, and an MRI?
Okay. Well, they're very different. A PET scan is basically a way of imaging the metabolic activity in the tissues of the human body. So basically, we take a radioactive sugar, we call it, it's called FDG, for fluorodeoxyglucose, and we inject it into the patient. And things that are rapidly dividing, like cancer cells, will take that up more than regular tissues. So they're going to be more radioactive than normal tissues. And then we put them in a machine that measures that and slices up the little bodies into little pictures of slices. And basically, metabolically active things are going to be very hot and very bright, and normal things shouldn't be. And so a CAT scan is just basically an X-ray machine that spins around, and as it's spinning, it creates a 3-dimensional image in a slice, and basically does the whole body usually. And we combine that with a PET scan, so we call that a PET CT. So you can see the bones and everything, and then you can see what's lighting up. That's a PET CT. An MRI is very complicated. It's a way of measuring the electrons spinning around a proton within molecules. And if it's in a magnetic field, it's very complicated, but different tissues react differently to the magnetic field and pulses of electromagnetic radiation that we shoot into the body. It's actually the same kind of radiation. It's not radiation like a CAT scan, because it does no harm. It's actually the same radiation that you find in a cell phone. But that radiation in a magnetic field will make tissues behave differently. And so we can just measure the differences between tissues. That's pretty much it.
There you go. Very good. Thank you. We have just time for a couple more questions here. This brings us back to Dr. Glaspie. There's a lot of interest about clinical trials. Someone wants to know more about the process of getting involved with a clinical trial, and most specifically, should it be free?
Yes, but clinical trials sometimes, actually often, involve adding something to standard therapy, right? So if you're in a clinical trial like that, what's standard therapy is billed to your insurance that would pay for the standard therapy anyway, and all the costs related to the investigational drug will be free. And all the study procedures related to the drug will be free, and any laboratory tests will be free that are required by the protocol that wouldn't have been required by standard care.
And our last question from the panel tonight goes to Dr. Slayman, and we looked at all of the remarkable slides you showed earlier, and it leads to this question, I think, and that is, are we getting closer to finding a cure for cancer?
hopefully I've convinced you the answer to that is yes, but if there's another thing that I hopefully did well was not that there is a cure for cancer, but that there are cures for cancer based on what's broken, and that the idea that we're going to find a silver bullet that's going to take all of cancer is passé. That's not going to happen. What's going to happen is sort of the old commercial about they earn money the hard way, they make money the hard way, they earn it. We've got to roll up our sleeves and figure out what pathways are broken and develop therapies that are directly attacking what's broken. And that, in theory, should give you more effective therapy and certainly less toxic therapy, because what's broken in the cancer cell is not broken in the normal cell. And that's what we're starting to learn. John showed you the slide of how complex these pathways are. And just amplifying on a couple of things that you all asked, everyone thinks, well, if you just get your whole genome sequenced, all the answers will be there. Remember, there's so many mutations that are made that there's a lot of noise there. So separating the wheat from the chaff is what really is what's critical here to find out what's driving the tumor versus what's just a passenger mutation. So just having sequencing data, which everyone thought for a while was going to be enough, is not sufficient. But there is no question. There are lung cancers, which used to be uniformly fatal, that are now completely survivable, and we use the term guardedly, but curable by just taking a pill once a day with no chemotherapy when you know what the mutations are. They're a rare subset of lung cancers, and that's where we're at with those, but it's real. The same is true with some types of leukemia with a drug called Gleevec, where while we were doing some of the HER2 work, I was also happening to be on service taking care of patients where we were treating these people with huge amounts of chemotherapy and whole body radiation and then giving them a bone marrow transplant. And that would have an improvement of survival for some percentage, and maybe about half. But many of them we lost as part of the therapy. But the disease itself in its late stages was always fatal, so patients thought it was worth the risk of trying it. Overnight, patients took a pill, and the disease completely went into remission with identifying what was broken in those. You're going to see more and more and more of that. And to John's point, who I think said it better than I did, is our objective is to get this out to patients in the community ASAP. Not just in the community, but globally. And we've sort of done that with things like the HER2 story, the Gleevec story, some of the other stories you've heard of. But we're here to serve. The university is supposed to support and make the lives of people in the community better. That's what the state used to pay us for. They don't pay much anymore. But we're doing this at several levels. And I want to end by introducing someone who hasn't been introduced tonight, who's a colleague who's helping build this whole capacity of bringing state-of-the-art medicine to the community and partnering with doctors in the community who do practice state-of-the-art medicine. That's Dr. Matt Denolfo. Matt, can you stand up? Matt is... Matt has led our efforts in terms of bringing primary care out to interface with the community hospitals and the community doctors at taking care of patients. So I think that the outlook for cancer medicine is incredibly positive. And I think that, and hold me to it, what you'll see in the next 2 to 5 years are therapies that we didn't even dream of just a little while ago. So I want to, again, add my thanks to that of my colleagues. I want to thank them for coming out tonight and all of you for coming out and spending an evening with us. And I want to thank Jim for the great job of moderating it. And finally, Robbie and her colleagues for having organized it. Thanks, Robbie.
Thanks to California Lutheran University, our host. And if you were not able to have a friend or loved one here tonight who would like to be part of the discussion, they have videotaped the forum tonight. It's going to be available on UCLA Health's YouTube channel, which is uclahealth.org. And we want to remind you can stop by those information tables provided by UCLA Health, the Cancer Support Community, and the American Cancer Society. And there's more information at the uclahealth.org website and Johnson Cancer Center website.